Okay. Now I'm gonna edit this, and I won't post it before I check in with you and make sure everything's okay with what you say. Um, all right. So my name is Sarina Galuga. I am the Director of Research for the Preparedness and Treatment Equity Coalition. And today we're going to be continuing to introduce you to this year's grantees for the Breast Cancer Health and Equities Research Grant Program, which is co-sponsored by Gilead Sciences. And today I have with me Dr. Sandra Melvin, who will introduce herself, and we're going to have an excellent interview. Okay. Hello, my name is Sarina Galuga. I'm the Director of Research with the Preparedness and Treatment Equity Coalition. I'm here today continuing our series, introducing you to some of the grantees for our breast health inequities research grant program, co-sponsored by Gilead Sciences. Today, I have with me Dr. Sandra Melvin, who will introduce her organization and tell us more about her work. Thank you for joining us.
Hello, everyone. Thank you for having me. I'm Sandra, Chief Executive.
Hello, everyone. My name is Sarina Galuga. I'm the Director of Research for the Preparedness and Treatment Equity Coalition, and we're continuing our series introducing you to our Breast Cancer Health Inequities Research Grant Program award recipients. And today we're with Dr. Sandra Melvin, who will introduce herself and her organization. We'll talk a little bit about her project. Thank you for joining us.
Hello, everyone, and thank you for having me, Serena. It's a pleasure to be here to talk about our work and some of the other important work that's going on throughout the country. I'm Sandra Melvin, the Chief Executive Officer and founding president of the Institute for the Advancement of Minority Health. And the mission of the Institute is to reduce health disparities within minority, underserved, under-resourced, disadvantaged communities here in Mississippi. And we do that primarily through partnering with other organizations here in the state to create solutions to address some of the most pressing health issues here in the state. And we specifically focus on the social determinants of health that we know influence poor health outcomes within these communities.
Mm-hmm. So can you tell me what drew you to this area of work?
Well, one thing that draws me is, as an epidemiologist, I have just looked at the differences in how minority communities are affected by health disparities. And it was alarming for me to see that in these communities, the primary issue is related to access and availability of resources. And if not, having the resources there, being able to access those resources. So for us, we know that the majority of the things that we die from are preventable. But within minority communities, they don't have or have not been given the and I don't want to say empower, because I think innately we're born with our own sense of being able to achieve what we need to. But I think there are some barriers in places in minority communities that prevent them from being able to access the resources that they need to live quality lives.
So you say there are barriers in place. So can you tell us a little bit about what you believe or what those barriers are?
Well, we know that in minority communities, a lot of times a major issue is just having access to care. And for us, that's compounded not just by poverty, the places that we live in. There's a saying that place matters. Not having green spaces to be able to go out and exercise, food deserts exist in those areas. And then there is, unfortunately, we have to address the issue of systemic racism and institutionalized racism that often reveals itself in legislation, particularly that targets low-income and minority communities, that keep them from accessing services that they should be able to have access to. And an example would be Medicaid expansion. We know that when we don't expand Medicaid, we primarily hurt minority communities who are already kind of falling in between the wage gap. So it's not that these communities or these people don't work. What happens is they get lost in that, balance of, I'm making too much to be able to get help, and I'm not making enough to be able to adequately access the services. And in Mississippi, we have one other issue. It's a rural state. We don't have public transportation like other communities do. So if they don't have transportation, that's just another factor that keeps them from being able to get to a hospital that may be miles away. And also, we have rural hospitals that are closing. So that takes away access. When you don't have the hospital there, when you can't get to the hospital, and then it's a healthcare provider shortage area, all that creates a perfect storm for someone to have a poor health outcomes.
So what are some of the areas of health that the Institute of Minority Health is working in right now?
Okay. Well, we have programs that work in the areas of maternal and child health, and that has kind of reached the top of the public health agenda all across the state, all across the country. And I'll even say that it's particularly necessary here because Mississippi has one of the highest rates of maternal mortality in the country. So definitely we need to have programs that improve maternal and child health. We also have among the highest infant mortality rates. HIV prevention is another issue because we have a high rate of not just STDs, but also, which is a risk factor for HIV, contracting HIV. So we do have an HIV prevention program. We have an opioid misuse program, and that is because we know that substance abuse feeds into other things. Substance abuse can be a factor that feeds into contracting HIV, as well as poor birth outcomes for mothers if they're addicted to drugs. Tobacco control. Of the leading preventable diseases, we know that using tobacco is a major risk factor that can lead to other chronic diseases. And then, of course, and this ties into the work that we're doing with the program, the PTC program, and it relates to health equity. Our project really focuses on some of the issues that affect equity, such as racism, discrimination, or whether the discrimination is real or perceived, it's still a factor. And so we look at, we have research projects that actually look at how racism, thoughts about racism affect how and when minority communities, and in our project, how Black women in particular access healthcare services.
So you started telling us a little bit about the project that's being funded by Preparedness and Treatment Equity Coalition. Do you mind elaborating a little bit more the um, about the project, um, the population that you're looking at, and perhaps talking a little bit more about how you're measuring people's experienced racism and also perceived racism, and how that's a critical part of the work that you're doing?
So, my thoughts and my philosophy about health equity does not mean people, when we talk about equity, sometimes we confuse it with equality.
Right.
And what I mean by that is we have areas in the state that they do have a community health center. They do have healthcare facilities. However, people don't use them. And for us, we think, well, maybe there's something else that's happening that causes people not to use those centers. Or there may be thoughts that people have that affect their health seeking behavior. And for us, and particularly in this project, what we're looking at is the impact of racism, perceived or real, and how it influences people's decisions. And in this case, women's decisions to access breast care services. Um, the idea is just because you put something there doesn't mean people will go to it. So it's just another um, expansion of our belief that in order for us to adequately address health disparities, we have to take it from a community perspective. And so with this project, what we're doing is we're reaching out to Black women, particularly in throughout Mississippi, and we're asking them questions about the services they receive at their facilities that they use, decisions about have they ever felt that they've been treated differently in those facilities? Do they feel any, a perception of racism when they go there? Because if that's the case, then when we talk about policies, it's not just legislation, it's also institutional policies that we want to change. Do they have do they have culturally appropriate services based on where that facility is? And so that's one piece of the puzzle. The other piece is, as a healthcare provider, as a human being, we all have innate biases. Now and it can be revealed in different ways. Bias can be explicit, such as overt racism, but it can also be bias in how providers treat patients based on what their perception is. For example, if a physician feels that Black women have a higher tolerance for pain, they may have a different treatment option for them. If the perception is she can't afford it, they may not prescribe the better treatment option and may go to something that's not as effective because of cost. But that's a bias. And so we have to address that. So one of the things we're doing too is we're implementing implicit bias tests among healthcare providers so that we can see that whether you admit it or not, there may be some things that you're doing just because, unconsciously you have a certain bias towards a community or whatever you may be thinking. When we say things like we assume people may be better dancers because of their race, that's a bias. You are assuming I'm the worst dancer you're ever going to meet. So, but we have to just and it's something that happens within all of us. And if we pay attention to that, we can make better treatment decisions because we recognize we come to the table with those biases. But also, I think that it can be used in medical schools. I think when we're talking about treating patients, it shouldn't just be, let me give you the problem or the disease and this is the treatment. We also need to make sure that people understand that they need to identify these biases, and they also need to take that into consideration when they're making treatment decisions with their patients, particularly if they're in low income, marginalized communities. And I do want to take this time to say, for us, we're the Institute for the Advancement of Minority Health. That doesn't just mean Black health. It also means any community, low income, LGBTQ. We deal with any community that may be treated differently because for whatever reason.
So you brought up earlier a really important point, is that Mississippi is overwhelmingly a rural state. Now, if you're trying to assess the experiences of Black women in the state, and they're kind of in these very difficult to access areas, particularly if we're talking about healthcare, how do you go about doing that? It seems like a really big ask.
Well, I think the first thing, and this is not just for this project, with any project that we have, we first of all engage the community, and we
Mhm.
engage the community all the time, not just when we have a grant. I think the mistake that a lot of people make is, I got this grant, but I've never been in this community, so the community doesn't know us. So the first thing that we do is, first of all, find out who is doing the work. We engage them, we engage community, and we engage community in different ways. We might create a community advisory board so that we can talk to them about the best way to even approach this issue in the community. We do listening sessions and focus groups so
Mhm.
that we can obtain detailed information based on their perspective. And I think the biggest thing is going into the conversation with a blank slate. So
Mhm.
we wrote this proposal, but we don't go into it having any preconceived notions of what the outcomes will be, because they may be what we think they are, but they may be something totally different. Maybe we think transportation is an issue and it's not an issue,
Mhm.
or, we come prepared to get the results based on what the community tells us.
Okay, that's a really excellent point that you make, and it's something that's really unique about your the Institute of Minority Health, is that a lot of this research is conducted in academic centers, which of course doesn't work that great for Mississippi, but even in more urban centers, like say here in the Northeast, there's a lot of communities that don't trust academic centers because they do kind of like drop in and then disappear and then come back in when they need something without creating longer lasting links with the communities and giving some kind of value back to the community. And that's kind of what you're doing. And so the one other thing that I am very curious about is, I think there are probably, some people at least who may be familiar with the concept of an implicit bias, and maybe even that there are like implicit association tests out there that aren't necessarily that great. But you're talking about specifically assessing implicit bias in the healthcare setting. How are you going about doing that?
Well, we are recruiting healthcare providers in all sectors, and particularly focusing on breast cancer too, breast cancer services. And we're recruiting them to participate in this study. And one of the things that you just said, which I think we have to understand why community-based organizations usually don't do this kind of research. Anytime you do any of this, you have to go through that IRB process,
Mhm.
and which is costly for some people. And so when you're a small organization trying to do these tests and you're going to be asking questions and having human subjects, you have to do that. The thing is, because of the background that the team has, we're able to, what people don't know is there are community based IRBs too.
Right.
And so we have a community-based IRB. So we go through the IRB process with everything that we do. So we do recruit the healthcare providers, and they agree, we consent them, and then we ask them the questions. And we also found a person who has done specific work in implicit bias, and she's leading that. And now she is at an academic institution.
Mhm.
But with her help, we're able to have someone, we're not just creating our own test or dealing with people, we're not kind of wandering through it. We were very thoughtful in that if we were going to do this, we know that this is such an abstract concept that we have to have someone who has worked in the field and is familiar with how these tests need to be run. And so she leads that process. And we talk to the providers, and we talk to them in a way that we're not trying to steer them in any direction. We just want them to answer and give their unconscious answer, not an answer that they've thought out.
Mhm.
And so that's pretty much how we have gone about it. And we are recruiting from community health centers,
Mhm.
clinics, hospital systems, so that we don't have the bias of this is a community health center as opposed to a big health system. We're taking providers from all of those areas.
Okay, that sounds really excellent. I think you made an excellent point. And people who are listening, who may want to apply in the future, and you're not attached to an academic institution, community-based IRBs exist, and that should not be a limitation. So thank you very much for bringing that up. So what drew you specifically to our breast cancer health inequity research grant program?
So we first started, this is the second initiative that we've done together. I will be honest, I've known Gilead through the HIV work that you all
Mm-hmm.
have done. But first of all, this issue is very much interesting to me because in the first initiative, we were actually looking at triple negative breast cancer, which is one of the most aggressive forms of cancer, and it commonly affects Black women. And so that's how we got started. We started looking at family history. Do people understand the relationship between family history and breast cancer? Also, the idea that, you know, Black women die at a higher rate compared to other groups when it comes to breast cancer. So that became a big issue for us, looking at breast cancer, looking at overall women's health, and then identifying breast cancer as one of the leading causes of death, particularly in Black women, and trying to see how we could really just expand our project. So we don't do our projects based on today we're funded for breast cancer, and once the funding goes out, we stop doing it. What we do is we look for points of expansion. So for us, the family history, knowing if your mother, your sister, you know, and then we found a connection between if men had sisters who had breast cancer, maybe that being a factor. It was just an extension of what we were already doing with Gilead in the past. And so now we're thinking, okay, if we're talking about health equity, we're talking about legislation like expanding Medicaid or access to healthcare services. Then I think looking at breast cancer, looking at, you know, race and discrimination, racism and discrimination as a factor should be something we look at as well.
So again, I'm going to come back to your being in Mississippi because so much of the research that's done in this country is really neglects areas like Mississippi. And you're in an environment where I imagine there may be some challenges in trying to implement the type of change in the healthcare system that will benefit Black women and other minority communities. Can you speak a little bit more about what the environment is like in Mississippi and how you hope that your work may help change things?
Well, I think Mississippi, we end up doing a lot of this type of research here because let's just be frank about what happens. When we're doing a needs statement for a grant, we're looking for the place that has the most issues, how that we can make the greatest statement. I'm just being honest about that. So the reality is a lot of money has been pushed into places like Mississippi because of our disparity burden. Okay. Now, the one thing I do want to say, yes, it's challenging because we do have, because of, you know, the makeup of our state in terms of our legislators, the beliefs of some people who lead this state. But I think that it also means this is the best place for it to happen. If we can make change given this political landscape, given this healthcare landscape, then we can do it anywhere. But here's the other point I wanted to make. A lot of times when we have this discussion, I get asked, well, you know, this is a Southern issue. This is an issue that's affecting people in the South. How do you deal with it? But the reality is, and especially with this project, when we talk about things like racism, perceived discrimination, implicit or explicit bias, we have to remember what's happening on a national landscape. So it's not just happening in Southern states. When we overturned Roe versus Wade, that wasn't a Southern decision. That was a national, you know, Supreme Court decision that affects all of the states. And so we have to just remember that. I think it gets highlighted because here in the South, racism tends to be a little bit more explicit. and overt.
Mhm.
But the reality is when we're doing projects like this and we're looking at bias, the bias occurs all throughout the state. And sometimes it manifests itself in decisions like Medicaid expansion, whether or not
Mhm.
to expand Medicaid. But the reality is even in the Medicaid expansion ruling, the decision was still left up to the states. And that was a United States Supreme Court decision. So if equity and if changing health was really at the pinnacle of what we were doing nationally and not just highlighting Southern states, the decision would not have been to let states make their own decision. It would have been to let Medicaid expand throughout the country. The only thing is we gave every state the opportunity to make that decision. And that's where the problem lies. And so, yes, we worked really hard to work in this landscape, but it's not just what happens here in Mississippi or in Alabama or in Louisiana. It also is what happens in Washington, D.C. when our Supreme Court justices meet and make decisions that we know indirectly are going to or directly will affect everyone in this country. Sometimes we just give them the weapons that they can use to make these decisions that they make on the state level.
Mhm. No, you make an excellent point. I think what's really important for people to remember that racism is not a regional problem. We have racism through every state and every territory of this country. And sometimes, like you point out, it's a matter of expression. And, for people to make the assumption, and like you mentioned, this is something you come up with over and over again, for people to make the assumption that a place like Mississippi is more like racist, whether that's quantitatively or qualitatively, is false. I live in the Northeast. People might say it's just different. It
Mhm.
looks different. That's all. It sounds different. But if you were to talk to many communities, and include myself in this, but if you talk to many communities here, I think you would find many of the same experiences that you will uncover in the work that you're doing if you came up here. And I worked on a project when I was in social work school with Black cancer patients. And we actually had a patient advisory council at a safety net hospital. And I imagine a lot of the experiences that you will uncover in Mississippi, you could see in Boston.
Mhm.
And we know Boston has a long history, but I just think it's really important to point out that it's, again, like you say, the results that you will find in your work are not applicable just to Mississippi or just to the South, but they're applicable to really minority communities writ large that are neglected by the people who hold the power and don't really have interest, a strong interest, or sometimes it's not even neglect. Sometimes it's actual hate against these communities, and therefore don't have an interest in making sure that their healthcare gets better, that their access gets better, that we address the social determinants of health that are leading to increased death from very manageable, treatable, or causes that can be eliminated.
Mhm.
So, I'm really glad that you brought that up, and that we make it very clear that the work that you're doing is applicable to anywhere in the country, but that it's also specific to Mississippi, because
Mhm.
those are the communities that you're working with. And so, can you talk a little bit more? You have throughout our conversation, but maybe some concrete steps that the Institute for Minority Health will be taking once this information has been gathered.
So yes, first, of course, we want to see what policies are out there that can be affected by our results. What
Mhm.
institutional policies can we recommend to be changed? Whether that's through working in partnership, because as a nonprofit, I can't necessarily lobby too much. I can lobby a little
Mhm.
bit, but working with people who are focused on that and creating some sort of partnership so that we can start really putting some data behind the recommendations that we're giving. I think the other thing is really educating healthcare providers. If we find that this is an issue, how do we have conversations with healthcare providers and people who are over the medical school curriculum to create, you know, curricula that really focus on, you know, culturally appropriate strategies, recognizing your biases and how they may affect treatment decisions. Of course, we're still in the struggle to talk about access to care and the things that block access to care. And then the other thing is racism, discrimination, part of that's one factor, but I think the other issue is how do we implement strategies to really overall affect poverty, which I think is really the main social determinant of health. Throughout this country, in areas that we see poor health outcomes, the one thing that we know is mostly constant is that these are poverty-stricken areas. And if you don't have the means, you have to use whatever facility is available to you, whether they have racist policies or not. You don't have a car. You may not have green space to be as healthy as you want to be. You may live in a place with crime, which increases your chances of something happening to you, which is a negative health outcome. So really looking at the policy, creating policy briefs, of course, creating a report that can be used with other organizations to help support the need for more work. So, and that's the other thing I noticed. We don't have a wide body of work produced here in Mississippi to really talk about the disparities. Most of the time, when we're talking about need, we're using either old data or data that is broad. It's not specific. It doesn't target specific communities and talk about specific things. It's broad in the sense that we'll say poverty or the prevalence of something on the state level. What about neighborhood level information? What about even developing training programs for clinics? Like when we do this survey, if we find certain clinics have been identified as being places that people have this feeling that it's a racist environment, then maybe we need to work with them on how to do training in service, the providers, the staff, so that we can make that environment a better environment for people in the community to use. So we can give that information back to the community too, back to the healthcare facility, back to the community to see what is going on and how we can work with them to make those things better and what's missing. So I think really creating communication campaigns to talk about what we found and just pretty much use policy, use information. Health literacy is another component. Do you know how to access? Do you feel comfortable asking questions because of what you think this provider may think about you? Are you scared to ask questions? So just kind of giving some sense of self-efficacy back to the community about taking over and managing their own health.
Sounds like you have a quite an excellent project on your hands, and I'm so glad that you applied to the program and we had a chance to meet you and learn about your work. And I wanted to say that one of the really important parts of this program that Gilead would like to get out of it is actually that dissemination and moving these results into policy. So I think, that's important for PTAC, that's important for Gilead, and I'm really glad to hear that's important for you, because we really want to make sure that these results don't just sit. That's really a chronic problem in academic research, and that's why we wanted to sort of break out of that mold and make sure that these results are disseminated, that people understand that. And even like so your research, specifically looking at Black women in Mississippi, but the research methods are the methods and they're easily translatable to other communities. And so you're creating a research structure that can work for other people so they don't have to recreate that wheel. So what's next for Institute for Minority Health?
Well, what's next? Of course, we continuously look for new partners that are doing the work because we don't think we can accomplish anything by ourselves. Continuing our partnership with Gilead, not just in the breast cancer work but also in HIV prevention work. And as well as looking at how we take those results, publishing those results, and not just publishing in peer-reviewed manuscripts, but also looking at how can we use the results from this program and other programs to really move us to the next level. I think a lot of us are in the business of giving away, doing community outreach events, but how do you take it to the next level? We're doing this research so that we can use this data to make change. And so that's what we're working on now. How do we assemble? And we do have a health equity task force. So how do we use this data to do exactly what you just said, to really create a political agenda based on the community results that we receive so that we can actually make some real change in the community and specifically here in Mississippi?
Well, with that, I think we have gotten a lot of really excellent information. I'm so glad that you had the opportunity to introduce yourself and the Institute for Minority Health to our audience. I invite people to look into them. They're a really great organization, and Dr. Sandra Melvin is like a force of nature. So I'm glad that you had the time for us today to talk about your work. And we will be looking forward to hearing more from you soon. Thank you for
you so
joining
much.
us.
Thank
Okay.
you.
All right.
Bye-bye.
Bye.